Envenomation bites. Now we will see about the snake envenomation. The objectives are to learn general aspects of handling a snake bite victim, to understand the clinical features of snake bite, to know the diagnostic studies of snake bite, to learn the management of snake bite. First, we'll go to a case. A 20-year-old female came to the emergency room at 2 a.m. with difficulty in breathing, pain, abdomen, anxiety, and vomiting. Take to primary health center and refer to the tertiary center. Airway, he had labored breathing, respiratory rate 30 per minute, SpO2 was 80% on room air. Circulation, his heart rate was 40 per minute with a BP of 60 by 30 and GCS of 3 by 15. He had fixed dilated pupils. He had no swelling, no pain, and no history of injury. Doll's eye movement were absent. Patient was intubated and connected to mechanical ventilator with 50% FiO2. Heart rate was 80 per minute and BP came around 110 by 70 with a saturation of 100%. So his pre and post blood gallons revealed initially he was in alveolar hypoventilation, and after connective ventilator, he almost became to near normal. The patient also became hemodynamically stable after connecting to the ventilator, but he was unconscious with dilated and fixed pupil. Investigations revealed an echo of normal ejection fraction of 65% and no wall motion abnormality. IVC was 1.6 centimeter with 50% collapse. CT brain was normal. Investigations revealed complete blood count was normal, no coagulopathy, and serum cholinesterase was normal. On day 1, patient was unconscious with fixed dilated pupil, Doll's eye movement absent, CT brain was normal and was connected to ventilator. On day 3, the consciousness improved, trying to open her eyes and pupil was equal, reacting to light and accommodation. On day 4, completely patient opened her eyes and obeyed commands. On day 6, she moved her upper and lower extremities. And on day 7, she flexed her elbow and knees. And on day 15, she performed her normal activity. And on day 20, she had complete recovery. We will talk about great snake envenomation. Great snake has a nocturnal habit and bite the victim only in night times. As the fangs are soft, it does not produce pain, swelling, or mark at the bitten site. You can see in the figure below. Small, short fangs of great. The patient becomes areflexic and has fixed dilated pupil. So the patient should not be diagnosed as brain death. Further, it produces axonal damage and the paralysis is predominantly presynaptic, and hence the anti-snake venom and neostigmine atropine drugs will not act in great envenomation. The recovery depends on the axonal recovery. Now we go to the case presentation 2. A 21-year male came to our hospital with an alleged history of viper envenomation over the left index finger. He was intubated. On admission, pain, swelling were present over the bitten area. Patient had bilateral ecchymosis and chemosis were also present. Blood investigation revealed altered renal function test and altered septic profile. Echocardiography showed global hypokinesia with an ejection fraction of 32%. So this is the viper head appearance, the patient with swelling and peritonitis and with chemosis. He was connected to the mechanical ventilator with the CMV mode with a tidal volume of 450, P5 and FiO2 of 40%. Injection anti-snake venom was given 30 vials totally. 2 units of fresh blood was given for coagulopathy. He was started on inotropic agent for reduced ejection fraction, and he was started on continuous renal replacement therapy with oxyris, that is septicemia cartridge, due to altered renal function test, septicemia, and hemodynamic instability. Broad spectrum antibiotics were started. So you can see the echocardiography on admission and ejection fraction was 28%, and after 48 hours, ejection fraction was 59.55%. Now we come to the snakes. Big four snakes in India are spectacled cobra, saw-scaled viper, Russell's viper, and common crane. These are called big four snakes because these are the four snakes which are responsible for the majority of death in India. How are you going to manage them? First, primary survey. The goals of primary survey: to retard the absorption of the venom, to preserve life and prevent complication before receiving hospital care, to control dangerous early symptoms of the venom. And what to do and what not to do in primary survey. To do is reassure the patient. The patient should not be excited and move about. Limb should not be massaged, and limb should be kept at rest. These all will retard the absorption of the venom. And we have to tie a piece of cloth around the limb. We should not do local insertion, attempt to suck the venom, apply tight arterial tourniquet, apply topical instillation of chemicals, herbs, or ice packs. Traditional five-side method should be discouraged, and they do more harm than good. So this is known as a pressure immobilization method, which can be done with an elastocrate bandage, and you can immobilize like this. But you have to be very careful once if there is necrosis, because it will go in for gangrene. The clinical features of snakebite. Signs and symptoms has 4 main categories: progressive weakness, bleeding, myotoxic signs, pain, progressive swelling, that is what we call it as PPS. The clinical presentation varies with the age, the size of the patient, species of the snake, number and location of bites, and quantity and toxicity of the venom injected. Symptomatic patient in neuroparalytic, they go in for progressive weakness, that is elapid envenomation. Elapid snakes are crate and cobra. Neuroparalytic snakebite patients present with typical symptoms within 30 minutes to 6 hours in the case of cobra bite, 6 to 24 hours for crate bite. However, doses in crate bite have been recorded as late as 36 hours after hospitalization. The symptoms has to be remembered as 5 Ds and 2 Ps. 5 Ds are dyspnea, dysphonia, dysarthria, diplopia, and dysphagia. 2 Ps are ptosis and paralysis. Coming to the vasculotoxic complications, vasculotoxic bites are due to viper species, and you have local manifestations and systemic manifestations. What are all the local manifestations? They are more prominent in Russell's viper, followed by saw-scaled viper, and least in pit viper. Local manifestations are in the form of local swelling, bleeding, blistering, necrosis, and pain over the bite site. Here you can see the formation of blisters over and around the site of the bite. Visible systemic bleeding from the action of hemorrhages, that is gingival bleeding you can get, epistaxis, hematemesis, hemoptysis, bleeding per rectum, subconjunctival hemorrhage, continuous bleeding from the bite site, bleeding from pre-existing conditions like hemorrhoids, and bleeding from a freshly healed wound. You can see epistaxis and hemoptysis, ecchymosis, and gingival bleeding. And the systemic manifestation includes swelling and local pain. Acute abdominal tenderness may suggest gastrointestinal or retroperitoneal bleeding. Lateralizing neurological symptoms such as asymmetrical pupils may be indicative of intracranial bleeding. Acute kidney injury associated with hematuria, hemoglobinuria, myoglobinuria, it will be followed by oliguria and anuria. Now we go to the painful progressive swelling. Painful progressive swelling is indicative of local venom toxicity. It is prominent in Russell's viper bite, saw-scaled viper, and cobra bite. Myotoxicity includes, normally it is common in sea snake bite. Patients present with muscle aches, muscle swelling, involuntary contraction of the muscles, passage of dark brown urine indicating rhabdomyolysis, compartmental syndrome, and cardiac arrhythmias occurs, which may be due to hyperkalemia, acute kidney injury due to myoglobinuria, and subtle neuroparalytic signs may occur. The investigations include 20 whole blood clotting time, and the CT will be prolonged, which is due to hypofibrinogenemia. We have to see for hemoglobin, platelet count, white blood count, biochemical abnormalities like creatinine kinase, aldolase and hepatic profile, ABG for metabolic and respiratory acidosis, ultrasound of the abdomen, especially kidney, urinary bladder, echocardiography to see the ejection fraction, ECG, and urine for proteinuria and RBC in the urine, the arterial oxygen saturation by SpO2, and signs of septicemia. So what is this 20-minute whole blood clotting test? This can be done as a bedside test in all the rural areas. This is known as 20 WBCT. Place a few ml of fresh venous blood in a small glass vessel. Leave undisturbed for 20 minutes at ambient temperature. Tip the vessel once. If the blood is still liquid, it is unclotted and runs out, the patient has hypofibrinogenemia, that is incoagulable blood, as a result of venom-induced consumption coagulopathy. Now we will go about the anti-snake venom management. The anti-snake venom comes in two forms in India. It is lyophilized powder form and liquid form. Lyophilized form has to be kept cool and it has a half-life of 5 years. Liquid ASV requires reliable cold chain and refrigeration, and it has a 2-year shelf life. What are the doses? For neuroparalytic snakebite, ASV 10 vials should be started as an infusion for 30 minutes, followed by second dose of 10 vials after 1 hour if no improvement occurs within first hour. Normally, the total dose should not exceed 20 vials. For vasculotoxic snakebite, two regimes are used: low-dose infusion therapy and high-dose intermittent bolus therapy. But the total dose normally should not exceed 30 vials. What is this low-dose infusion therapy? 10 vials of Russell's viper or 6 vials of saw-scaled viper as stat infusion over 30 minutes, followed by 2 vials every 6 hours as infusion in 100 ml of normal saline till the clotting time normalizes, or for 3 days, whichever is earlier. This high-dose intermittent bolus therapy, 10 vials of polyvalent ASV are given 30 minutes as infusion, followed by 6 vials 6 hourly as bolus therapy till clotting time normalizes and our local swelling subsides. What are the dose of ASV in pregnancy and children? Children and pregnant women also are given exactly the same dose of ASV as adults, as snakes inject the same amount of venom in children and adults. For pregnant women, refer to the gynecologist in case of any impact on the fetus. How are you going to manage the pain? Analgesia is an essential component of snakebite management. Intravenous opioids are preferred initially. For severe pain, narcotic analgesic like morphine sulfate should be used, which should be used with caution in respiratory failure. Dextropropoxyone or paracetamol can also be used. Buprenorphine analgesic patch is used nowadays successfully. Coming to the management of complications of snakebite, we have got management of neuroparalytic complication, coagulopathy in snakebite, acute kidney injury management, hemorrhagic complications, hypotension and shock, and capillary leak syndrome. Coming to the neuroparalytic complication, 3 milligrams of neostigmine along with 1 milligram of atropine sulfate should be given slowly intravenously initially. This should be followed by 1/3 the initial dose every second hourly intravenously, and the dose is gradually tapered. Premature discontinuation will lead to relapse. This should be followed by simultaneous administration of the ASV. As atropine has a tendency to produce delirium, glycopyrrolate can be substituted for atropine, which should be combined with neostigmine. If neostigmine-atropine combination does not reverse neuromuscular block, and if the paralysis of the respiratory muscle occurs, then the patient requires ventilator support. The indications of mechanical ventilations are respiratory rate more than 35 breaths per minute, tidal volume less than 10 to 15 ml per kg body weight, PO2 less than 60 millimeters of mercury with an FiO2 of 60%, PCO2 more than 45 millimeters of mercury with a pH less than 7.35 and absence of cough and gag reflex. Usually, ventilatory support is required for around 10 days for elapsed snake bite. Coming to the coagulopathy, is usually seen in Brussels viper in South Asian countries. It is coined as venom-induced consumption coagulopathy. Criteria for severe coagulopathy are INR more than 3, APTT more than 50 seconds, platelet less than 5,000 cells per cubic millimeter, and fibrinogen less than 75 milligrams per deciliter. Whole blood transfusion takes care of this coagulopathy. It also provides adequate hemoglobin for oxygen transport. Antifibrinolytic agents are not effective in snakebite victims. If platelet is less than 50,000 per cubic millimeter, we have to give 2 units of fresh frozen plasma, and platelet concentrate is transfused every day till the platelet count starts improving. Single donor platelet STP can also be used with beneficial effect. Management of kidney injury, administration of 200 milligram of furosemide at 4 ml per hour, that is 40 milligram per hour, intravenously should be given, and urine output is monitored, which is known as furosemide stress test. Furosemide converts the oliguric phase to diuretic phase. To minimize the risk of renal damage for myoglobinuria and hemoglobinuria, we have to correct hypovolemia. Renal shutdown occurs, hemodialysis is contemplated. Early prophylactic hemodialysis will improve the survival, and in hemodynamically unstable patient, CVHT or CVVHT can be instituted with a CRRT machine. How are you going to manage the capillary leak? Snakebite produces septicemia, which releases cytokine, which produces damage to the endothelial cells. In one side, there is loss of protein-rich fluid. In one side, there is loss of protein-rich fluid. So if there is loss of protein-rich fluid, it worsens, and there is fluid in the third compartment, like extremely edema, pleural effusion, gastric and intestinal edema, muscle edema leading to rhabdomyolysis. On the other hand, it produces hypotension and acute kidney injury, and it may be leading to ATN. So, for acute kidney injury and hypotension, volume resuscitation improves. On the other hand, volume resuscitation worsens if there is third fluid space, which has to be substituted with albumin or hetatarch. What is the take-home message? Continuous examination of the bitten site is essential to prevent the local manifestations, especially in viper bite. As the fang of the crate are soft, it does not produce pain, swelling, or mark at the bitten site. The patient becomes areflexic and has a fixed dilated pupils. So the patient should not be diagnosed as brain death. Further, crate produces axonal damage, and the paralysis is predominantly presynaptic, and hence the ASV and neostigmine atropine drug will not act in crate envenomation, and recovery depends on axonal repair. Coagulopathy confirms the diagnosis of hematotoxic snakebite, and acute respiratory depression confirms the diagnosis of neuroparalytic snakebite. Complete dose of anti-snake venom should be administered. The dose of anti-snake venom remains the same for children as well as for the pregnant women. Symptomatic management should be done in order to prevent multi-organ dysfunction syndrome. Management of complication is crucial to reduce mortality. Now we go to the question session. Which of the following should not be done in a snake bite victim? The limb should not be massaged. Tight arterial tourniquet. Limb should be kept at rest. Tie a piece of cloth around the limb. It is tight arterial tourniquet. Which one of the following is a clinical features of neuroparalytic snake bite? Blisters, bleeding, ptosis, and necrosis. It is ptosis. Myotoxic effects are more common in saw-scaled viper, krait, cobra, and sea snake. It is sea snake. Which one of the following investigation does not play a role in snake bite? Coagulation profile, septic profile, lipid profile, and renal function test. It is the lipid profile. Maximum dose of ASV in viper envenomation are 20 vials, 30 vials, 25 vials, and 28 vials. It is 20 vials. Total dose of ASV in a child bitten by a neuroparalytic snake is 25 vials, 18 vials, 20 vials, and 10 vials. As already told, the dose of ASV is equal for adult, children, and pregnant women. Criteria for severe coagulopathy is INR less than 3, APTT less than 50 seconds, platelet less than 50,000 cells per cubic millimeter, and fibrinogen more than 75 milligrams per liter. It is platelet less than 50,000 cells per cubic millimeter. Which one of the following is ineffective in the management of hematotoxic complication of snake bite? Whole blood transfusion, single donor platelet, antifibrinolytic agent, and fresh frozen plasma. It is antifibrinolytic agent. False statement about the management of neuroparalytic envenomation. Neostigmine atropine combination, atropine glycopyrrolate combination, neostigmine glycopyrrolate combination, and simultaneous administration of ASV along with neostigmine. It is atropine glycopyrrolate combination. Which one of the following is a non-venomous snake? Saw-scaled viper, common krait, cobra, and rattlesnake. It is the rattlesnake. So these are all the references for snake bites. Thank you.